Okay, guys, so chapter 18 we spent quite a bit of time in class on, and I tried to record it in class, and I just wasn't happy with, well, one, there was a lot of weird stuff being said in that class, but I didn't want to, I wanted to go a little bit, redo it a little bit on the anatomy side, because the simple fact is you're going to have to know for the test purposes, you're going to have to know the anatomy of the heart and know it very, very well. So I wanted to spend some decent time discussing this with you. So I wanted to redo the recording. So I'm sorry it's a little bit late, but it took me a little bit to find some free time to sneak away and get this done for you guys. But when it comes to the cardiac cycle, which is the pumping and the blood circulating and how all the anatomy works, you're going to have to know the four chambers, and you should know that: the right atrium, left atrium, the right ventricle, left ventricle. There's a tricuspid valve. There's all that kind of mitochondrial valve. Um, you know all that kind of stuff in the body, in the heart. There's a vena cava. There's the aorta. Um, the descending thoracic aorta. Um, all that is you're going to need to know for the anatomy. So memorize, read the chapter, do the best you can to memorize these things because there's just not enough time to go over it with you. Um, but anyway, I got a book um, on how the body works, and bought it when I was in class, and it actually really is amazing to study the human body on it. It's called How the Body Works, and when it comes to the heart, there's all kinds of stuff that it dissects in there for you. But for today, for this chapter, for the cardiac emergencies, you just have to really understand the cardiac cycle. And what that is the series of changes within the heart which causes blood to be pumped throughout the whole body. So again, it's divided into periods when the heart muscle contracts, known as a systole, and a period when it is relaxed, known as a diastole. So that's where we get systolic and diastolic blood pressure, right? So systolic is when the heart muscles contracts, and the period when it is relaxed is diastole. And the ventricle then fills. So during the diastole, when the muscles relaxed, the tricuspid and mitral valves are open. So the diastole is when it's muscle relaxed. So that just like the lungs, you're right. When there's the relaxate, there's the active and inactive. So during the distal, the tricuspid and mitral valves are open. Blood from the great veins, which veins carry the blood back to the heart, right, fills the atria, and then it passes through these open valves to fill the relaxing ventricles. Um, so that's how that works. When the ventricle for the ventricles to be filled, the diastole and tricuspid and mitral valves are open when it relaxes. Blood from the great veins fills the atrial and then passes through these open valves to fill the relaxing ventricles. Okay, so kind of hard to picture. So what I would say to you is, right, if you pause this video for a second, if you can find a picture of the heart, which you should already have, you're in a cardiac emergency book. So if you open it up to a picture of the heart where it shows the four ventricles, that should give you a pretty good picture where I'm describing this. So then during the contraction, the arterial contraction, as the relaxation ends and the systole begins. So again, systole is when it contracts. The SA node sparks off a contraction of the arterial muscle, which forces more blood into the ventricles. And then the ventricle contraction, the wave of contraction reaches the ventricle via the AV bundles. So there's the wave of contractions reaches the ventricles, and the fibers, the tricuspid. I'm just trying to remember everything here. So then the tricuspid, at that time, and the mitral valves snap shut as pressure increases. So again, the muscles relaxed, the heart muscles relaxed, the ventricles fill with blood. So then when it contracts, the SA node sparks off a contraction, and the tricuspid and mitral valves snap shut as pressure increases. The blood pushes against the closed pulmonary and aortic valves and causes them to open. As the wave then contraction dies away, the ventricle relaxes, and then the cycle begins again. And with the SA node, the impulse, it's about a second later. That's why it's so fast. Everything we just described to you is like bump, 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 bump. So it's the SA node is kicking it every second or two. But the muscle, you got to remember though, the muscle relaxes, the ventricles fill up. The SA node sparks a contraction. When that contraction, all the valves snap shut and the blood's pushed out to say it quicker. So hopefully you'll pay attention to that as much as you can. Re-listen to it and find a picture to look at. And then you can also go to YouTube and all kinds of videos to find. Nicole has sent you guys all different websites to look at. So with that said, that's part of the anatomy. Now another thing I want you guys to understand on the anatomy side is the artery pumps blood away, oxygenated blood away. That's why when there's a arterial bleed that we have, that at that time the blood's really bright red. And I've seen this. It is like as red as you can. I mean, I've never seen it. It's just crazy red, glows in the dark almost, because it's got so much oxygen in it. So, but then veins carry deoxygenated blood back to the heart, right? So the aorta pumps, or arteries pump blood away. That's oxygenated. All the veins carry deoxygenated, it's oxygenated pores, what's called, to the heart. But there is one exception to the rule on that, and that's the pulmonary vein. So the pulmonary vein carries oxygenated blood from the lungs to the left atrium of the heart. This is an exception to the rule that veins carry the oxygen poor blood. So, however, it does follow the rule that arteries carry blood away from the heart while veins return blood to the heart, except for the pulmonary vein. The pulmonary vein carries oxygenated blood from the lungs to the left atrium of the heart. That's the only vein. That's the only exception to the rule. Okay, so hopefully not confusing you, but I wanted to give you. You're gonna have to know these anatomies, and you're gonna have to know it pretty darn good. Okay, so with that said, we'll move on with a little bit further into the chapter. So cardiac anatomy and physiology, which we just did a little bit of. Flow of blood through the chambers of the heart, the cardiac we just went through that with you, the conductive system, composition of the blood, flow of blood through arteries, veins, and all that good stuff, which we just talked about as well. Review the cardiovascular system, so circulation of blood between the heart and lungs and between the heart and the rest of the body. So, when you look at this picture here, basically like we said, so the artery pumps oxygenated blood away from the heart. Veins bring oxygen poor blood back to the heart, except for the pulmonary vein. But this is a great picture. Hopefully, you were looking at this when I was kind of describing everything to you, as it was. So, just picture all that. The blood comes in. Muscle relaxes. The blood comes into the. Okay. Sorry, I had a kid come in. We're watching some friend's dog, and it was getting crazy here. So again, you look at this picture here, you can see it really well. That during the relaxation part, the tricuspid and mitral valves are open. So if you look at, I think it's in this picture. There it is, a tricuspid valve. Is right there in the middle. Okay, so then it relaxes, that opens up. And so then what happens when it opens up, the blood from the great veins fills the atria and then passes through the open valves to fill the relaxing ventricles right below. So look at this picture here and just picture that, and get that pictured. There's the tricuspid valve right there, relaxes, and so does the mitral valve. And the mitral valve is right across from it. So those two valves, which is kind of like doorways, relaxes so the blood flow can come in and fill those ventricles. Then the SA node kicks in a contraction with the atrial contraction. So then the muscles of the heart, so basically the mitral valve snaps shut and the tricuspid snaps shut as pressure decreases, and then the blood pushes against the closed pulmonary and aortic valves, and it causes them to open. So they snap shut, and then the contraction pushes the blood to cause them to open, and all that blood flows where it needs to flow from there. So, and then you got just through the anatomy stuff, you look at these things, you're gonna have to know that. You're gonna have to know the pulmonary valve, the right atrium, You got the aortas there, the interior vena cava, and then the pericardium is going to be have to. I remember seeing that on my registry. It's going to have to be known, and that's just the sac that goes around the heart. So, anyways, take a good look at this, the four chambers, and then the flow, how the blood flows. So, you got to the lung, which is left pulmonary artery, right? You got the aorta pumping blood away. You got the super vena cava. You got the right pulmonary artery pumping things out. And then you got the veins bringing everything back in. Okay? So, I know I'm throwing a lot at you right now. So, um, just work with it the best you can, guys. You guys are doing awesome. I'm so happy you guys are sticking with it, and it's going to be awesome having you guys on the team. So, ACS, acute coronary syndrome. Fun stuff here. So sometimes called cardiac compromise. So anytime the heart may not be getting enough oxygen. So acute coronary syndrome, sometimes called cardiac compromise. So it's a blanket term that refers to any time the heart may not be getting enough oxygen. Simple as that. There are many different ways in which patients' hearts show that they are in trouble. So one of these is that there's many different kinds of problems with the heart. So many different kinds of problems under the ACS heading that we have to see. Symptoms often mimic non-cardiac conditions. Symptoms often mimic non-cardiac conditions. And that's the thing is a lot of times you're going to have people that feel like they're having heart issues or not. They have just pain in their heart, pain in the chest. They can be multiple things. Treat all patients with ACS like signs and symptoms as though they are having a heart problem. So even though it may not seem like they're having a heart problem, if we don't have a diagnosis ourselves or have an idea, we treat it like a cardiac problem. Chest pain is best known, can be described as crushing, dull, heavy, or squeezing. So we've discussed this, that someone's sitting on my chest, there's a vice around my chest, or someone's just like a bear hug. Typical, like sometimes it feels like a rubber band squeezing. Sometimes described only as a pressure or discomfort. And we've all had stuff like that. You know what I'm talking about. Not necessarily a cardiac problem, but we've had where we felt pressure in our chest. Well, there's something wrong in your chest, and your body's trying to tell you. So, a lot of times, that's it'll just be something they say is a pressure or a discomfort. A cardiac problem will radiate along arm, down upper abdomen, or up the jaw. So again, just picture where the heart is, right? It's right behind the sternum, sitting between the lungs. And basically, if there's a problem there, or squeezing or pressure, if there's a heart not working, function problem, just picture where that is. The pain's going to radiate. It's going to go down the arm, it can go up the jaw, or right there at the upper abdomen, kind of where the diaphragm is. Dyspnea is also found in ACS. So, shortness of breath may be the only finding that some of these patients have. They're like, man, I just can't. I'm having trouble catching my breath. Oh my gosh, and so that's what you're going to have to intervene with. Some other symptoms is anxiety, feeling of pending doom, and you guys have heard me say, and I'll say it again. Always listen to your patient. If they feel like they're going to die and they say it verbally, get them to the hospital quick. I mean, that's a good sign. Nausea and pain or discomfort in the upper abdomen, epigastric pain. So they're nauseous, acid reflux, which is can be the epigastric reflex or pain. Sometimes GERD, if they're having an issue with their heart, it could be a GERD symptom as well. A lot of these people think they're having heartburn. Sudden onset of sweating, diaphoretic, big time, abnormal pulse. So either tachy or bradycardic, right? So, that's a common thing. If their heart rate is abnormal, if it's tachycardic or it's bradycardic, obviously it's not working properly. Abnormal blood pressure. So obviously if they're tachycardic, bradycardic, typically they're going to be hypotensive. Patient's assessment. So you do your assessment. You get on scene, perform the primary assessment, and just for back up for a minute, for test purposes, so patient assessment. So basically you've already got the scene size up, taken care of. You got your BCI. The scene is safe. You're now in the house. Perform your primary assessment. Get that history. Get that physical exam. Use that OPQRST. So what was the onset? What's the pertinent history? What is the quality of the pain? Is it 1 out of 10? 10 being the most you've ever felt in your life? Does it radiate anywhere? What is your sign? Severity? And then time. When did this all start? So get that history, present the illness, obtain that past medical history. So now you can take the past and line it up with the present. Is what they're dealing with abnormal today? Is this a new symptom, sign and symptoms that you're seeing compared to what they had in the past, right? So um, you're going to have to check all those things. Um, and then get that baseline vital signs for the to follow trends. Patient care, you place the patient in a position of comfort, um, typically sitting up, like that, like the guy in the picture in your book. Typically, they like to sit up. If they lay down, it can be a little bit of affect their breathing more. Determine if oxygen should be administered. Look at that pulse ox. I mean, look at their ventilation. Are they getting good ventilation? Is the respiratory rate in a good spot? Is their pulse ox in normal range? If it's not, you can get them on oxygen, and then transport. So that guy right there, he's got oxygen, checking vitals, getting the family history. We're getting history from the family. If trained, equipped, and authorized to, which we will be, you will be, obtain that 12 lead. Basically, what a 12 lead does. It really gets a picture of the heart. That's the best way to describe it. So that monitor that we have, which is an awesome thing, is a BLS to be able to have that monitor. So that monitor is a pretty cool deal because it's an X-ray vision. They can get into the human body and see what they're dealing with, see what's going on inside. So a 12 lead is basically a picture. It takes different directions of the heart and shows you whether you're having a heart attack or not. We can't interpret the wave strips, but we can interpret everything else that it says because it says it. It's not interpretation, it's just reading it. But we can also send that 12 lead strips to the hospital in advance. So if you're in Kit Carson, you got 25-minute transport, get a 12 lead on the scene, snapshot it with your phone, send it off to the doctor, and they can take a look before you get there. And then also you can give it to them while you're there with your report so they can match it with what they just did to see if there's any changes. So follow local protocols, which we do those things. That's our protocols. So patient care, indications for administration nitroglycerin. So indications are chest pain, history of cardiac problems, and prescribed nitro. Obviously, it has to be prescribed because we don't carry nitro. We can assist them with their nitro. So a physician has prescribed nitroglycerin, so we can assist them with their nitro. So remember the right route, right drug, right time, all that good stuff that you learn in pharmacology. So the fact is we can't help them with anybody else's nitro, only theirs. That's tablets, goes under their tongue, dissolves. Indications for administering nitroglycerin. So their systolic pressure meets protocol criteria, right? So about that 90 to 100 systolic, because we don't want them. Nitro is going to dilate that vein, artery, the arterial walls, right? It's going to dilate, so it's going to change that blood pressure. So it'll lower it. So we don't want to lower it anymore if they're already low. So if they're hypotensive, nitro is off the table. Patients has not had Viagra or similar drugs that are there any kind of erectile dysfunction drugs lowers blood pressure. So basically, if they have any of that going on, we don't. Medication and direction authorized administration of medications. Get medical director, get on a horn with our hospital. Let them know what you're thinking about giving nitro, and always cover your butts that way. It's a good thing to do. After giving a dose, if nothing's changed, we can give another dose. Patients experience no relief. The systolic blood pressure remains greater than 90 to 100. So we gave them a dose. Nothing's changed with the relief. Their blood pressure is still above that 90 to 100 systolic. Medical direction authorizes another dose. So give another one. Chest pain for aspirin. So if you want to give aspirin and they're having chest pain, great. That's one of the things that we look at basically is if there's chest pain going on, give them aspirin. I mean, it's not going to hurt anything unless they have some contradictions. But they're not allergic to aspirin, so we can give it. They have no history of asthma. So I did research a little bit more after our last conversation in class. That really threw me. And I actually even talked to some nurses and doctors, and it threw them too. So apparently it's a fairly new thing. But yeah, aspirin-induced asthma. Who would have thought? Patient not taking medications to prevent clotting, so they're not on blood thinners. If they're on blood thinners, you don't want to thin that blood anymore. So basically, if they have chest pain, they're not allergic, they don't have asthma, and they're not on blood thinners already, give them 5 tablets of 81 milligrams, or 8 tablets of 81 milligrams. So indications is no other contradictions to aspirin. Ability to safely swallow. I mean, if they're not able to swallow anything, don't give it to them. Medical direction advises us to. So we're in our department, we're waivered. We don't have to seek medical advice, but again, if you ever have questions or second guessing yourself, do it. Chewable aspirin, that's what we give. We give this 81 milligrams each. So really, according to the proper dosage, we can give, I think, up to 8 tablets en route. So some causes of these cardiac conditions. Heart problem caused by a number of disorders affecting condition and function of blood vessels and heart. So a heart problem caused by a number of disorders. Affects the blood vessels in the heart. So conditions that narrow or block arteries of the heart. So coronary disease is something that narrows and it blocks the arteries. So it prevents that flow. Often results from fatty deposit buildup on inner walls of the arteries. So basically it's like plaque buildup, fatty tissue buildup around the walls, so it narrows the blood vessels. So blood flows it slows down. It takes a lot more pressure to get through those arteries, or it gets through the veins and arteries. So buildup narrows inner vessel diameter, so restricting the flow of blood. So basically, all you're talking about is traffic jam. I've said this before. It's kind of any kind of buildup that narrows the inner vessels diameter. So you got, your vein and the tunnels, right, that the blood flows through, carrying oxygen to the body. So as things build up inside, it narrows that down. So there's less of it takes a lot more pressure to get that blood moving. Thrombus. So the occlusion of blood flow caused by formation of a clot on a rough inner surface of diseased artery. So disease is just what it sounds like, a disease, dis-ease. So there's a dis-ease in the artery, and it's helping form a clot on the inner surface. So that can cause a problem, and it can break loose and form an embolism. So when that clot is there, it's building up, and then one day it just gives out, and now you got an embolism that takes place. And that's where pulmonary embolism, it can happen in the brain, it can happen anywhere really. So an emboli can move to an occluded flow of blood downstream in a smaller artery. So basically that emboli can move, and then it can build up, it can jam up in a smaller artery somewhere and prevent the blood to stop flowing there. Reduced blood supply to the myocardium causes emergency and majority of cardiac related medical emergencies. So reduced blood supply to the myocardium. So go back in your book, right, into the picture, or go to the picture in the book that shows the heart. So when you get to that picture, just take a look and find the myocardium. So reduced blood supply to the myocardium causes emergencies in the majority of the cardiac-related medical emergencies. So the problem with this is the myocardium is the area of muscle fibers enabling the heart to contract or beat. Okay, so it's the muscle that causes that contraction, the beat, bump, 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 bump. So a lack of blood supply to that area is going to cause pain, but it's going to cause problems getting the blood flow because there's not proper contractions. It's the rhythm. So that causes most of the issues. And if there's not enough blood and oxygen flow there, eventually it causes muscle death. So then you got, it's just without that you got nothing. So it takes a lot of, it's just a game stopper really in someone's life if that is a problem taking place. So an aneurysm, weakened section of the arterial walls begin to dilate and balloon. So an aneurysm and a bursting can cause rapid life-threatening internal bleeding. So right there, an aneurysm. So there's a buildup there. So again, you can see in this picture, the weakened wall balloons out. Well, the reason this is taking place is when there's a clot that can build up there, but all that fatty tissue building up inside that, narrowing that wall, causes more pressure for the blood to flow, and then things happen. So anyways, it weakens the wall, and boom, you have an aneurysm. And it takes no time at all for death. Malfunctions of heart's electrical system. results in a dysrhythmia. Uh, that cause bradycardia, tachycardia, obviously, and rhythms that may present when there is no pulse. So the SA node is the electrical system of the heart. It kicks in those contractions. So when that goes south, you can either get a tachycardia, get bradycardia, any kind of different arrhythmias. And then when there's actually no pulse, you can still get arrhythmia because the SA node is contracting, boom, boom, causing all that. So mechanical malfunctions, angina pectoris, chest pain in the pectoris range, acute myocardial infarction. So an AMI, it's a massive heart attack, is what that is. And then congestive heart failure, so CHF. So anyway, all those are horrible. So chest pain caused by an insufficient blood flow. So let's start with the angina pectoris to the myocardium. So chest pain. So again, that's where I said the muscle is the myocardium that helps cause the contractions, lack of blood flow, it causes pain. So typical due to narrowed arteries, secondary to coronary artery disease. And so in your book, there's a good section here on this. So the pain of the angina pectoris comes on after stress or exertion. The pain will frequently diminish when the patient stops exertion. As the oxygen demand of the heart returns to normal, the pain subsides. Seldom does the painful attack last longer than 5 minutes. Possession of nitroglycerin is another indication that the patient has a history of this condition. So nitroglycerin is a medication that dilates blood vessels and helps that blood flow get to that myocardium. So the fact is when they're exerting themselves, they're demanding more oxygen to that heart, and they can't get more oxygen to that heart because they have too much blockage of their blood flow. So basically, then what happens here is simply the fact is that's why they take nitro, and they take nitro, it dilates and helps that blood flow go, and it relieves pain. So, but when they rest, okay, so if they're after they get the chest pain and they take a break, the oxygen demand is less and causes the pain will subside. So pain usually during this time increase during such demands. So just got to watch those things. So the main thing is though nitroglycerin. So if you're on a chest pain call and you find out they're on nitroglycerin, you can think angina pectoris. This is an issue. Is an issue. Acute mitochondria, so death of the portion of the myocardium due to lack of oxygen. So in your book, you see a picture. There's a part of the muscle there that is dead because it didn't get enough oxygen. That's where you cause a heart attack. So usually by the time someone has a heart attack, they've already got dead muscle tissue or dead muscle tissue, and they test for that because it shows in their blood. Coronary artery disease is usually the underlying reason. So coronary artery disease. So there's that picture. The blue is the dead muscle. There you have infarct, and yeah. So the congestive heart failure is inadequate pumping of the heart. Often leads to excessive fluid buildup in lungs and or the body. So excessive fluid. So maybe brought on by diseased heart valves, hypertension, obstructive pulmonary disease. All those can cause CHF. Often a complication of an AMI. So you have a complication of an AMI. It can cause congestive heart failure. So it just builds on each other. Patient sustains an AMI, myocardium on the left ventricle dies. So because of the damage to the left ventricle, blood backs up into the pulmonary circulation and lungs, CHF. So if untreated, left heart failure commonly causes right heart failure because it's just too much work. Your heart, you got to understand, your heart is a miracle. The fact that it can beat 70 times a minute for your whole life and is only the size of a fist is an extraordinary feat. But the fact is that the left ventricle, so if the AMI, the left ventricle dies, because the myocardium didn't get enough oxygen, fluid can back up into the pulmonary circulation of the lungs. So the fluids build up. Now you can drown. You get that. It's just a lot of issues there. But then eventually, if it doesn't get fixed, the other part of your heart is going to die as well. So some signs and symptoms is tachycardia, dyspnea, cyanosis, normal or elevated blood pressure, diaphoresis, and pulmonary edema. So Again, tachycardic, so heart rate's going to go up. Your dyspnea, you're going to have labored breathing, which is going to cause cyanosis, and your blood pressure is normal or elevated blood pressure because you're tachycardic, and diaphoresis and pulmonary edema. Um, Anxiety or confusion due to hypoxia. So if you're not getting enough oxygen, obviously you're not getting it to the brain. You're going to be hypoxic. Pedal edema, swelling of the legs and feet, engorged pulsating neck veins. Late sign. That's a bad day. If you go on a call and they already got the pulsating neck veins, that's a bad day. Enlarged liver and spleen with abdominal distension. Late sign as well, because everything's going to swell, fluid buildup. So cardiac arrest. Yay. So 5 elements: immediate recognition and activation. Come on. So anyway, yeah. The bottom line is immediate high quality CPR increases survival significantly. So about the only time it does not help is when defibrillation reaches the patient within approximately 2 minutes. Since this rarely happens in real life, EMS agencies need to address this factor. There are at least 3 ways in which CPR can be delivered earlier. Get CPR trained professionals to the patient faster, train lay people in CPR, and train dispatchers to instruct callers on how to perform CPR. An efficient way to get CPR to patients faster in many areas is to send CPR trained professionals to the scene. This may mean police, firefighters, security officers, and lifeguards. These professionals need to receive notification of the possible need for CPR as soon as possible. They also need to be in the right place so they can respond quickly to where they are needed. So I just read all that to you from your book, just because it is important. The fact is immediate recognition and activation of CPR saves lives. Rapid defibrillation, effective advanced life support, integrated post-cardiac arrest care, and the teamwork around you and coordinating all that. So there is nothing more important. If you get a page out, if you're getting paged, for someone who is unresponsive, unconscious and unresponsive, man, that's a bad day. Get there quick. Don't take your time, dilly-dallying around. If you're on the call docket, just get there as fast as you can. But the same thing, we got to train. I believe we got to train more people in our first response unit with CPR. Not everybody's CPR certified. But it can definitely make a difference, especially when you're being paged out to someone like Kit Carson or Arapaho. It requires prompt notification of EMS system, most likely a bystander responsibility. And that's true. If we could train more lay people in the community, someone just walking by might be able to help. We already read that. So high performance CPR changes implemented in resuscitation efforts. So compressing the chest at least 2 inches in depth in adults, allowing for full relaxation on the upstroke of compressions, and then spending half of each compression on the downstroke and half on the upstroke. So spending half of each compression on the downstroke and half on the upstroke. So anyways, it's just all this is rhythm. You want to get that 2-inch depth, but it's just rhythm. You don't slow down. Bump, 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 1 and 2 and 3 and 4 and 1 and 2 and 3 and 4. It's like a dance move. But anyway, so you just want to be able to get those good depths and good compressions to get that, because you got to imagine is if you picture the chest, that heart's right below that is right behind that sternum. So when you push that 2.5, you're contracting that heartbeat. You're pumping that blood throughout the whole body, and so you actually got to really be thinking about what you're doing. And if you picture that in your mind of what you're doing, every time you push that heart, you're contracting those vessels to the tricuspid and to open up and let that blood flow to the body. High performance. So using correct hand positions, compressing at least 100 times per minute. So imagine that. There's 120 seconds in a minute, so you're really hitting it. You're not dilly-dallying around. And I know you learned this CPR class, but it's okay to get, repetition. Spending no more than 1 second on each ventilation. So when you stop at 30, and you don't want to spend a whole lot of times breathing. 1, so breath, compressions. Minimize interruptions of CPR to no more than 10 seconds. So when you are on scene and you're compressing and you got someone doing airway and you get the AED on, so the point is when you're doing CPR, someone else is putting that AED on, and if you don't have somebody else there, you're just compressing. Get at least 4 cycles in, I think they said in CPR, and then, but you don't want to stop 10 seconds to put the AED on. So whatever you do, just don't interrupt whatever system you're working with. If you're going to hook up a Lucas, if you're going to put on AED, which you're going to, but whatever phase you're in, if you're putting the AED on first and then you're putting Lucas on later, just do not stop more than 10 seconds because it changes the outcome. Key is increasing cardiac output. Since most cardiac arrests in adults are the result of cardiac problems, not respiratory problems, there is enough oxygen in the bloodstream to maintain metabolic process for several minutes. So that's why we're okay. So you get on the scene, it's ABCs, but when you got a cardiac arrest, it's now CAB or CBA. So circulation, is a big deal there. And the rule of thumb is proper. I mean, the fact is someone's taking breaths, they're breathing, right? Um, unless it's someone who died of COPD, respiratory distress to arrest, and then their heart quits. But if it's just someone normal, they're walking down the street and they're breathing. They breathe in, they have a heart attack, boom, they hit the ground. They have oxygen in that blood. The problem is the blood's just sitting there in their body. It's not perfusing. So when you get on the scene and start compressing that heart, bump, 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 now you're perfusing that oxygen throughout the body. You got time to get them oxygenated. The sooner the defibrillator arrives, the more likely the patient will survive. There you are, rapid defibrillation. So effective advanced life support generally provided by EMTs, paramedics who respond to scene or rendezvous with BLS unit en route to the hospital. So with us, we're EMTs. We don't got paramedics here yet. So we're EMTs. So we show up and we got everything we need. Rapid transport to hospital may be the most time efficient means of obtaining ALS. That is absolutely true for us. So for test purposes, though, learn both ways. Learn to work with ALS in the scene, because that'll be test, and then also learn ALS, we got to get there to the hospital. So coordinate numerous means of assessment and interventions that together maximize the chance of neurological intact survival. So great point right there. So the fact is we're perfusing the body, circulation, right, compressions. But now that we got compressions going, we also got to make sure that we're doing everything we can to, if this guy lives, we're going to keep him neurologically intact. So oxygen, oxygen, and oxygen. So get those compressions going, but don't forget about the airway, right? And in the field, what we would do, and I'm just going to tell you this for our standpoint, read the book for test purposes too, but for our standpoint, when we're working a cardiac arrest, we're pumping that heart, we're intubating according to what we can. We carry king tubes and we carry eye gels. We get that airway patent, so that's one way of doing it is by tubing them, and then we're breathing for them. So now we're breathing in compressions, and then we're also going to get fluids going through the IV access. And then we're going to transport. But we can get all that done on scene and then begin transport because all those things matter for life. When you have a cardiac arrest, sometimes we're like, oh my gosh, we got to load. I've seen ambulances carry someone dead to the hospital because they didn't do anything. They didn't do CPR. No, guys, we're going to do CPR and we're going to get that airway going and we're going to get fluids in the veins. Fluid is important because what good is blood flow? Because you got to know this person right now at this point is dead. I mean, your heart, you're beating their heart and you're breathing for them. So fluid helps carry that oxygen and that blood through the body as well. So we got to get fluid in there. So IVs, IO, compressions, and intubations and breathing. We're doing all that to make sure we get that neurologically intact survival as a possibility. Okay, so and we'll go more on that when you guys pass and you're part of our department. But as of right now, for test purposes, that is part of test purposes. But that's a great point with neurologically intact. Maintaining adequate oxygenation, like I just said, avoiding hyperventilation. So we don't want to be adrenaline junkies and hyperventilate the person. Just easy breaths, one every 8 seconds, every 5 seconds. Breath, breath, breath. Performing 12 lead and EKG. So one of the things, if we got long transport with this cardiac arrest, we're going to constantly be checking for shockable rhythm, but we're also going to hook them up to a 12 lead so we can watch what's going on. Man, we got the ability with our equipment to be able to watch the heart beating as we're pumping it, to tell, are we getting good beats or are we not getting good beats, right? Fighting and managing treatable causes of the arrest. We don't know. Maybe they overdosed. Give them some Narcan as well. Determining appropriate destination for the patient. And I want to back up for a minute on that is, I worked a cardiac arrest a while back too, and one of the things the hospital did find in the blood labs was drugs. I didn't even think about Narcan. I just know the guy died, right? So I'm gonna start with compressions. We're doing airway. Did everything else right, and we didn't necessarily do anything wrong with this either. But the fact of the matter is, we could have tried Narcan. Even KMH after that incident, they put up part of their protocols for cardiac arrest, Narcan. So maybe that's a manageable, treatable cause of the cardiac arrest. We don't know. Determine appropriate destination for the patient and possibly inducing hypothermia. That's way out of our scope. I don't think that's in KMH's scope. EMTs provide two links in the chain of survival: early CPR and rapid defibrillation. So there you goes a picture. AEDs hooked up, compressions are going. Perform 1 and 2 rescue CPR, take standard precautions. Use an automated external defibrillator. So basically when we're pumping the heart, we're also getting that defibrillator hooked up. We carry two. We carry the AED, which is the easiest for everybody. But we also, on our monitor, life pack that we carry, also has an AED. So we can actually do an AED and hook up the 12 lead. We'll get an LS. Basically, we're going to radio KMH, say, hey, we got a cardiac arrest. CPR is in progress. We're getting everything stable, and it'll be en route to you. Use a bag valve mask device with oxygen. Use flow restricted oxygen powered ventilation device. We do have that ability too, or we don't here. We're going to order it. There's something called a PEEP valve. You can control the ventilation power to help protect us. Lift and move the patient. Suction patient's airway. No matter what, usually with cardiac arrest, you're going to have suctioning taking place. Because the chances are too, if it's cardiac arrest, if something really did happen, an aneurysm or whatever, you're going to be suctioning a lot of blood. Use airway adjuncts. Keep that airway patent. Interview bystanders and family members about what happened. We got the semi-automatic. It advises EMTs to press the button that causes the machine to deliver shock. So that's what we got. We hook them up. If we just use the AED, it says shockable rhythm, shock advised, and then we push a button. Boom, shock. Fully automatic, does not advise EMTs to take any action, but delivers the shock automatically. Classified by types of shock delivered. So there's the monophasic, sends signal shock from negative pad to positive pad. And then the biphasic, sends shock in one direction and then the other. I got to learn more about AEDs. Apparently, I don't know what that necessarily means. I'm sure it's in the book, so read it. Analyze cardiac rhythm to determine whether shock is indicated. Anyway, that's just kind of the treatment sequence that the AED will use. Good to know. How AEDs work is the most common condition resulting in cardiac arrest are shockable rhythms. So ventricular fibrillation and ventricular tachycardia. So VFib and VTAC. There's different kinds of most common conditions resulting in cardiac arrest. There are shockable rhythms. VFib and VTAC. And you hear that, like if you ever watch ER or Chicago Fire, they're in VFib, they're in VTAC. So anyways, the fact is most of the patients you'll run on if they're in cardiac arrest are going to be VFib. And basically what that is they have a shockable heartbeat, but it's just chaotic. It's all over the place. It's just, it's just everywhere. There's no organization to it. It's disorganized. Now VTAC is just basically it's very fast. It's basically designed to shock a rhythm known as VTAC, so it's very fast. And VTAC, cardiac arrest rhythm observed in less than 10% of all hospital cases. The heart rhythm is organized, but it's usually quite rapid. So just very tachycardic, 245, 250, 275. It just gets way out there. Where VFib is just all over the place. It's unorganized is the best way to describe it. Interrupt CPR only when absolutely necessary and for a short period as possible. CPR must be paused for rhythm analysis and defibrillation. Perform primary assessment. If bystanders are doing CPR when you arrive, have them stop, and help you. Verify. Um, but anyway, so yeah, I mean, but if there's a bystander doing CPR, have them stop, and then you want to verify that they're pulselessness, they're apneic, and absent of other signs of life, no longer than 10 seconds. So give it time, but then when you're checking that pulse, you're going to find out, is it VTEC, is it VFib, or is there nothing at all? Are they apneic, which is basically the last cycle of breaths taking place if they're dead, is the best way to describe it, I think. Read your book for a better definition, but that's the way I look at it. And that there's absent of life. Do that for 10 seconds. Check the pupils. Are they blown? You know. Apply the AED. Bare patient's chest. Open that, trauma naked. Rip that shirt off. Quickly shave area where pads will be placed if necessary, and if available, use the pediatric AED pads. If using adult pads, do not overlap. That's a big thing because they get very big. This is, obviously. Turn on AED, attach pads to the cables, and then do to the patient. Stop CPR and then analyze. And we're going to do that all the way to the hospital. So if we're transporting this person, we're going to stop probably every 5 minutes, 10 minutes, and check. Clear patient and shock if indicated. Immediately begin CPR after delivering a shock and reassess patient after providing 2 minutes or 5 cycles of CPR. And keep that timeline. Every 2 minutes, check. Now, when you're at the hospital working a cardiac arrest, and I'm going to tell you something, I would really appreciate all of our EMTs staying at the ER and helping. It'll be a great experience for you, but also really helps our staff at the hospital too. But they're giving epi too, so they'll give epi. So everything I said, right? Intubation, breathing, compressions, IV access, IO access. Well, then at the hospital, we're also giving epi. So every time they give epi, in 2 minutes, you check again. If AED finds no shockable rhythm, we'll advise that no shock is indicated. Pulseless electrical activity. So that means they're not in VFib, they're not in VTEC. Everything is stopped, it's ceased. They're astal. Resume CPR immediately. When providing CPR, compressions must not be interrupted for any longer than 10 seconds. We've already covered that, so we're getting repetition a little bit, but compressions at least 2 inches deep and keep that going. When providing CPR, rate should be at least 100 per minute. If a patient wakes or begins to move, obtain baseline vitals, administer high concentration of oxygen, and transport. So you'll have these moments too. You just saved a life. Great job. They're waking up. Get that baseline vitals instantly so you can follow trends and get them on oxygen to replace everything they lost. Help that neurological survival and transport. General principles. One EMT operates a defibrillator while another does CPR. CPR must include high quality compressions. Defib comes first, and you must be familiar with the model of the AD used in your area. So we'll teach you all that, but you guys know from CPR, but we'll also teach you a life pack. General principles: all contact with the patient must be avoided during rhythm analysis. Pulse checks should not occur during rhythm analysis. So when you do a rhythm analysis, you don't want to be doing any compressions or touching them or anything. Stay clear and be sure everyone is clear of the patient before delivering every shock. Check the batteries at the beginning of your shift and carry a spare. Now I'll tell you this, guys, is as a department, if we do on-call schedules, that's my goal for everybody. I think it'll make everybody relax. Actually, we have to go to scheduling. I just found out from the state, but anyway. Every beginning of your shift, sometime at the beginning of your shift, I'm going to have a checklist so everybody can check. Because when it's just one guy like me checking everything, well, I try to do it monthly for most things. But at the same time, guys, it's one guy, I can make a mistake, miss a battery, and then the Lucas doesn't last very long for CPR, and you're in trouble. So main thing is we'll have a checklist. So when you're on shift, check the batteries at the beginning of your shift. We want to make sure everything's covered. If you have delivered 3 shocks and are without backup, prepare a patient for transport. An AED is often not able to analyze the rhythm accurately in a moving emergency vehicle, so we have to pull over if we're going to do that. And that's okay. I've done that before. We're cardiac arrest over in Kit Carson all the way to Shine Wells, and we pulled over repeatedly to check for shockable rhythm. Coordination with ALS personnel, notify as soon as possible to greater the patient's chance of survival. If the team arrives before you have finished the first shock, they should allow you to complete the shock. Your actions may depend on location of the rest and estimated time of arrival to the ALS team. And then, guys, want to think about that. If you're out in Wild Horse area, man, we got a long way to transport. Um, so um, survival really will determine our distance. And these people chose this. The one thing is, you don't want to feel bad. People chose where they live, knowing things like this can happen. But when we're on that call, our judgment to go to the closest facility and how we're going to get there does save lives. Let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved, so they can look at how things are done. Your protocols will dictate transfer of care. Coordination with others who defibrillate before you arrive. Let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital. Now I'm being repetition. I just read this slide. I apologize. I thought it changed. I had a lot of distractions. Kids are around. If patient has a pulse, manage the airway. Avoid hyperventilation. So if they do have a pulse, patent airway and avoid hyperventilation. Just breathe for them. Keep defibrillator on patient during transport in case patient goes back into arrest. Reassess frequently every 5 minutes. So consider hypothermia protocols, which we can't do, but manage the airway so they're back around. Manage that airway. You keep the AED on, get that baseline vitals, and then keep checking. If patient has no pulse, you will need to resume CPR. AED will give you a no shock indicated message. AED may be prompting you to analyze the rhythm because it thinks there is a shockable rhythm. So, and they can't think there's a shockable rhythm. You know, the fact is that whatever the SA node is doing is what that thing's going to pick up. Ensure adequate ventilations of oxygen. Just amount to no more than what is necessary to achieve oxygen saturation of 94%. Protocols may require you to place the patient in therapeutic hypothermia. Use techniques of lifting and moving, which we can't do that, so test purposes. Stop the vehicle and resume CPR. Have someone else start CPR if the AED is not immediately ready. Analyze rhythm as soon as possible. Deliver shock if indicated. Continue with 2 shocks separated by 2 minutes, so 5 cycles. So anytime that you're doing this, 5 cycles, check for shock. 5 cycles, check for shock. That might be a good time to also change who's doing compressions. It will wear you out. It is a lot of work. No guarantees, but very good chance of reviving patient because you can defibrillate very shortly after a patient goes into shockable rhythm. So stop the vehicle, treat the patient like any other patient in cardiac arrest. Apply the AED, defibrillate immediately once shock delivered. No shock indicated. Begin chest compressions after 2 minutes. Check rhythm again, and shock is needed. Pads won't fit on the patient without touching each other. Trauma, that's a contradiction. Do not let those pads touch. Trauma with severe blood loss or damage to one or more vital organs. So that's the thing is when you got a thoracic trauma, it's hard to do CPR. You won't use a Lucas on those people, and that's contradicted. You can't really do a lot. It's a tough thing. Do not defibrillate soaking wet patient. Dry them off. Do not if we get a call to the pool, we got to dry that patient off before we hook up an AED. Do not defibrillate a patient touching anything metallic that other people are touching. The fact is if we get called to the wind towers and there's a cardiac arrest in the tower and they're laying on steel, you can't hook an AED up. Remove nitroglycerin patches before defibrillating, and verbally and visually clear a patient before. It can be performed on a patient with implants surgeries. Defibs cannot be performed on a patient with an implanted device. It'll shut the device down. Positions defib pads on patient's chest to avoid contact with the device. So common sense there. Some devices or surgeries you may observe in the field include cardiac pacemakers, implanted defibs, a ventricular assist device, and cardiac bypass surgery. So you got to look for all those things before doing anything. Quality improvements, involves getting medical direction, initial training, maintenance of skills, case reviews, trends, analysis, strengthening links in the chain of survival. So one thing is we do all that. Um, if you're questioning anything, get on the horn with medical direction. We're going to continue with different trainings, and then we want to maintenance of the skills. You got to keep getting CPR certified. We want to keep you up to date on those things, and we always do case reviews. I mean, with me anyway. If there's a tough case, we're going to review it. We're going to debrief on it. We're going to spend some time till we all do better. Use checklists at every shift to ensure all the supplies, AEDs, and function properly. Make sure batteries is charged and you have a spare with a defib. I'll tell you this much: is we don't want to be those people that show up and have a dead battery and it screws everything up. So as a team, we're going to help each other be accountable to make sure that stuff's done. Mechanical devices assist EMTs to provide high-quality compressions. Using Lucas CPR device, stop CPR just long enough to put the Lucas base plate under the patient, apply stabilization strap before moving the patient, and upon termination of arrest or return of spontaneous circulation, power down. So, yeah. So our Lucas, basically, I showed you guys in class, we throw it on there, right? You stop compressions, take 10 seconds, put it on, get it going. You don't want to move them until they're strapped to it, and then also, if they spontaneously come back, we power it down so we can't use it. Auto pulse we don't carry. I have used them. I like them. Align the patient on the auto pulse. Provide bag ventilation at a rate of 2 ventilations for every 30 compressions, and 2 minutes of CPR. Reassess for pulse and shackle rhythm. Once you start resuscitation, you must continue it until spontaneous circulation occurs. They start, and then we give them rescue breaths as needed. Spontaneous circulation and breathing occur. Another trained rescuer can take over for you. So we do not stop CPR until we can have someone take over for us. That's important. If you get tired, you get a backache, you just tough through it until someone's there to help you. You turn care of the patient to a person at a higher level. So we're doing CPR, we're doing all the way to the hospital. We do not stop CPR until we hand it over to someone RN or above. You are too exhausted to continue, so there is that, but I don't want to be that guy that someone dies because I was too tired. You receive a no resuscitation order from a physician, DNR, that kind of stuff. Criteria to determine when it is reasonable to stop without missing anyone who has a chance of survival. Arrest not witnessed by EMS personnel or first responders. No return of spontaneous circulation after 3 rounds of CPR and rhythm checks. We don't call time of death as EMTs, so that's a paramedic and above that would do that. We do 3 rounds of CPR. They're not back yet. That's not our call. Once you start resuscitation, you must continue until criteria is determined when it is reasonable to stop without missing anyone. An AED did not detect a shock rhythm and did not deliver any shocks. So chapter review, read through that, guys. Hope that helped. I went a little bit more on anatomy in the beginning, but listen, cardiac arrest is a pretty simple call to run. It's just a little bit scarier. So for test purposes, you're going to want to remember all of those reasons of termination of CPR. The fact is really, here our protocol is we can't stop unless there's obvious signs of death. Which we wouldn't even start if there's obvious signs of death. But I mean, really, medical direction will be helping us as we're doing it. So just read through your book, read through your chapters, and you guys are doing great. Appreciate it. So read through these reviews, and then we'll go through some of these questions to consider in critical thinking in class. So thanks, everybody. Hope that helped.